My name is Miquel Ensenyat. I come from Spain. I'm working at Duke University right now. I arrived 7 months ago. I arrived in May, and I did my thesis in Mallorca in Spain. And I have focused in breast cancer and in glioblastoma in my PhD. And now I have focused more towards breast cancer, and especially in precision medicine, using things like machine learning, artificial intelligence, these type of things, to try to give each patient the best treatment. For example, in my work, we work with immune therapy, but not all patients respond to this treatment. So what we use is gene expression data, with is a huge amount of data. There are more than 20,000 genes, and using all of them is very difficult, and most of them are just noise. It's not relevant. But what we used is machine learning, random forest, to select only the specific genes that can predict which patients will respond to immunotherapy and which ones will not. So in this way, we can just give each patient a therapy that they will respond to, and we don't add extra therapies that they are expensive. They have adverse effects, and we only give it to the patient that really need it. In this conference, we presented about lymph node invasion. It's a similar project, but in this case, we presented a different machine learning based, another artificial intelligence algorithm. And in this case, it's to assess the nodal infiltration in breast cancer patients, because some patients have higher or lower nodal infiltrations, and they need different therapies or different dissection of the axilla. And this is an invasive procedure. And we are trying that only the patients that need to have this complete dissection of the axilla have this procedure, and the ones that they don't need it, they can avoid it. Yeah, we use the DNA methylation, like the epigenetics that Diego mentioned before, that it's how the environment affects the genome of the patient. And in this case, we use this DNA methylation to see what patients have more nodal infiltration in the axilla, more nodal invasion, and these patients will need a complete dissection of the axilla. This is a procedure that is really invasive, and which ones have a lower invasion when they have some infiltration in the axilla but not much, they don't need the complete dissection. With only the therapy that they receive for the main tumor, for the primary tumor, it's enough. So this way we can avoid this process if they only have a little bit of infiltration in the axilla. Yeah, for right now, this has not been done in a prospective way. This has not been done for patients. It has been in retrospective analysis, but to apply this in the future, it would take some years before we can apply it to new patients, because we need bigger cohorts. We need to validate all the findings. We need the approvals and everything, big clinical trials. So this will be a few years before we can start to apply it in patients. And then once you are using it in patients, it's just a 2-week process to make this array, to make this process to see if that patient will need the complete dissection or not. This is typically for patients who are already receiving the treatment. Maybe they will be receiving neoadjuvant chemotherapy for the primary tumor, but this is just to try to give the fewer therapy that we can to the patients. This is one of the goals of the conference. We are seeing many conferences about this in this conference and in past, because now patients are overtreated most times. We give them many treatments because we don't know to which part of the treatment they will respond, which part is necessary, which part is not. We know that giving them 3 things, 60% of them respond. And if we only give them two things, only 40% respond. This means that there are many patients who don't need that extra treatment, and we are trying to discover which part of this treatment is unnecessary for which patients. So in this case, it would be the same. It will be the patients that are already starting the therapy, which part of the therapy they can avoid. Yeah, in this case, we didn't focus in like a specific epigenetic sites. I mean, we didn't check the biological effects of the changes, but we only used the DNA methylation as a predictor, as a classifier, that we didn't check what is that DNA methylation doing in the patient. But having this feature means that you need to have this complete dissection. So this is something that we are working now, but we haven't arrived there yet. We have used many different cohorts. We started this project using clinically available data. We always start using public data because we believe that it's something that data is not used enough. I mean, we are constantly generating new data, and there is a lot of data that we are not using because maybe you create a whole cohort, you have a lot of data, and you only check this small part. And we are trying to go to these cohorts that they include hundreds of patients, so with different characteristics, white patients, African American, Asian patients, normally from the US because it's from where the cohorts are made usually, but they are only using this small part of the cohort, and we are trying to use this information and expand it. And then in this project, we have used two different cohorts from Duke University and from UCLA University, including hormone receptor positive, HER2 negative breast cancer with early tumors. One of the problems is that it's not standardized. Right now, it has improved a lot in the last years. When you try to access studies from 10 years ago, it's impossible. You cannot access that data. I think it has improved a lot, but we still need a standardization of what you have to upload when you upload the data, because some people, especially with the clinical data of the patients, it's always de-identified. I mean, we never access identified clinical data, but sometimes they only include this small amount of clinical data, and it's impossible to make other studies different than what they have done. I mean, they have a cohort where they have studied response to chemotherapy, for example, but they don't include anything else apart of that. And if we try to include all the clinical data that we can always identify, we can make a lot of more use of all this data. I think this is improving. I think that it's more by the journals than anything, that the reviewers of the papers are saying, okay, you need to include all the data. A few years ago, they just didn't say it. It's also helping with the code with the bioinformatics, with the analysis. Now they're also asking to include the code that you have used to analyze, so we can replicate the results and everything. But I think that we are lacking like a major regulatory organism that can regulate the data that is uploaded and how it is uploaded. But it is very difficult because most times this comes from clinical trials with private funds, and in these cases we just don't have access to any data. It's not uploaded, and it would be great if they shared a little bit more of the data that they are doing.
When it comes to uploading the code, are there any conversations around standardization or of the code and how the machine learning is built out or things like that?
No, with the code, everyone uses its own code.
Because I'm thinking about how machines can have artifacts and things like that.
Yeah. This is an issue. I think it's less an issue that it was with the clinical data, but with the code we have at least you can replicate it. You have the exact code and you have exactly what they did with the data. You can replicate it 99% of the times. There are things that cannot replicate because they are based in, for example, the random forest has this random component, so you will never be able to do the same true forest. And this part is you just have to believe that it has been done correctly. But no, there is not a clear standardization with this. I think that with this type of system, it's difficult to explain exactly what we are doing. I mean, if we just say we are looking if the node is bigger or smaller, it's easy to explain to the patient. They will always collaborate because it's easy. And we are not finding any problems, so that patients do not collaborate or anything. But I think it's more difficult to explain to them what we are really doing. Because saying, no, we are using 900,000 CPG sites with different things, and then we are using random forest to identify a classifier that will merge these many things and will give a score that will... I think it's more difficult for the patient to understand that this can have a clinical benefit for them and not for them, because when they give us a sample, they don't have the benefit because the experiments are very slow, but it will have a benefit for others in the future. And I think that it's important that we can explain this to the patients so they can just, that they want to collaborate, not that they just say yes if we ask, but they are willing to do it. I think that the subtyping of breast cancer subtypes will be really important. I think that right now, for example, in TNBC, in triple negative breast cancer, you are giving the same treatment to all patients. And this is something that is unacceptable at this point, that, okay, you don't have hormone receptor expression, you don't have HER2, you have chemotherapy. Okay, that for you. And immunotherapy maybe. And I think that it's very important that we can give each patient a different treatment. We have many options, we have many lines of treatment, and if we know that this patient will respond to something that right now is the third line of treatment, why should this patient go through the two first lines of treatment? Why can't we go directly to the third line? And I think it's very important that we can select the line of treatment that will be better for each patient initially, and don't go with chemotherapy, immunotherapy until you find the right choice of treatment. Yeah, this is a big issue. And for example, we have done also a study with comparing white American and African American patients. And it has been a big problem because we haven't found data from black patients. We haven't found this type of data. We had to dig in the data. We had thousands of white patients, but so few black patients. It's very difficult to when we try to do this. And if we go to, for example, European cohorts, it's even worse, because we are biased to the people who has the money to do the experiments, and this has been seen in clinical trial during a long time, and it's also happening now in the data.